Welcome to A Shot in the Arm podcast. I'm your host, Ben Plumley, and this is the podcast about innovation and equity in global health. Well, the World Health Assembly is kicking off in Geneva, and it's one of the most critical assemblies in the World Health Organization's history. As the Director General, Tedros Adhanom, presents his much reduced budget and staffing structure recommendations to member states, facing an even more tempestuous and uncertain terrain than last year. And I'm not there this year, but Yvette Raphael is, and we'll get the skinny from her as it happens. I'm grounded, staying here in California, continuing to try and discern a positive, long-term agenda for global health, one that's rooted in the leadership of affected communities and their elected officials, one that brings the fruit of biomedical science and health technology to them as soon as these innovations become available in developed world markets, and where northern global health strategists like me are on point to be available to these communities to answer their questions and support their strategies. And that's why I'm thrilled to be joined by our guest today. But before I introduce him, just a reminder that we can't do this without your support. If you haven't already, please subscribe to our show wherever you get your audio podcasts. And we're really trying to build up our audience on YouTube. So please visit our YouTube channel at www.youtube.com/@shotarmpodcast. Like this episode, subscribe, and hit that notification button to be notified when new episodes are out. And now back to our guest. He is a brilliant physician, outstanding policy analyst, an advocate who I hope we will see much, much more of at A Shot in the Arm podcast in the future. It's Dr. Mike Reid, Associate Director of the Center for Global Health Diplomacy and Delivery and Economics at the Institute of Global Health Sciences at the University of California in San Francisco. Welcome to the show, Mike.
Thanks, Ben. Great to be with you. Lovely privilege to be here. Good afternoon.
Good afternoon. Well, look, our listeners and viewers will note that you and I have more than somewhat similar accents. Do you want to tell us a bit about your background and how you ended up in the US?
Sure. I grew up in rural England, about 30 miles west of London. Trained in medicine at Cambridge and then London, and began my clinical work in the National Health Service. But I always felt drawn to places where medicine intersects with justice. And so I ended up coming to the US for further training, and eventually global health work drew me in. Spent the rest of my career working in HIV and more recently pandemic response activities. I guess often in places where the stakes are highest and the voices are quietest.
Yeah, well, apart from my lack of any medical training, I think I've sort of followed a path a bit similar to yours, even as it relates to our academic training. You went to Cambridge University, so did I. I think probably a good, actually 10 years before you. I went to one of those dreadful modern colleges, Churchill College on the outskirts. Where did you go to college at Cambridge?
I also went to one of those dreadful colleges on the outskirts. Actually, not dreadful. I went to Robinson College, which is a modern red brick monstrosity, but a bastion of liberal thinking and edgy 18-year-olds who were anxious about social justice, which was why I was drawn there.
I mean, in hindsight, I'm quite proud of Churchill. Britain's answer to Massachusetts Institute of Technology. And I think I was the only person there who read theology, believe it or not. So, yeah, I had a terrific time, and I learned a significant amount about how to think about how people are influenced, how they think, and who they turn to. So it was, I think, a brilliant education for me.
Excellent.
So anyway, let's get into it. One of the first things I wanted to pick your brains about was global health and global health security in particular. And coming out of the COVID pandemic, in our field of global health, there's been quite a discussion about whether the health security angle is still valid, or whether we should be looking at more of a global health solidarity agenda. It's something that friends and colleagues at the Global Health Council have been pushing, and I'm really keen to get your thoughts. And I'll say up front, I'm a unreconstituted Richard Holbrooke global health security person who completely agrees with the idea that security has to be defined in terms of healthy societies worldwide are important for our own security. But I'm really keen to get your thoughts.
Well, I would say that the CDC definition of global health security, which is really focused on infectious disease threats and pandemic threats, is a fine way of framing the issues at hand. But it is quite narrow, and it assumes that the world's biggest health threats are new viruses or zoonotic infections, and it assumes that the threats caused by infectious diseases are the only things that matter. Or not the only things, but the major things that matter. In reality, health security is also about resilience, about the ability of people and systems to absorb shocks and still deliver care, right? So I think in that sense, global health security needs to entail economic security, because healthy people build prosperous economies. I think it has to involve food security, because nutrition underpins immune responses. I think it encompasses climate security, because rising temperatures are already reshaping disease patterns. And probably it even encompasses military and political security, because instability often follows after outbreaks and health collapses. I mean, we saw that with COVID to some extent. I would also say, though, that the framing of health security has often had a north-south, high-income, low-income dichotomy to it, where oftentimes the threat is perceived to come from low-income countries. And I think that is shifting. And I think COVID has really helped us kind of rethink our paradigm around how we are vulnerable as a global community. I think the African philosophy of Ubuntu is really relevant here. I am because we are, right? Kind of a different framing for global health security, and a heuristic that really thinks about that sort of interconnectedness and tries to frame health security not so much as something that should be securitized, but really as a sort of an opportunity for cross-country collaboration around shared collective threats.
So I think COVID is a really good example of where South security was betrayed by global North security. The vaccine populism that hindered the global South from accessing many of the COVID vaccines really indicated that the sense of solidarity was actually very hard to generate. And there were some really interesting experiences from countries in particularly Africa as they mounted their own organic COVID responses that, frankly, I think countries in Europe certainly, and yes, states in the United States could really have learnt from. But I also think that, you're absolutely right to emphasize these other linkages, and climate particularly. When we look at refugees, I mean, we think of economic refugees at the moment, but it's going to be climate refugees increasingly in the coming decades. And if we don't help build resilient communities, then trying to block off our borders and close our borders is really a fool's game, because how high does a wall have to be? It will never be high enough.
Right. It's a great point. I think even before COVID exposed issues of vaccine apartheidism, there are other examples, though, where we failed to facilitate the kind of collaboration that would have been ideal. I mean, the very fact that Omicron was detected in South Africa and Botswana should have been an opportunity to sort of celebrate their infrastructure and their capacity for rapidly detecting that very infectious variant. But what it led to was a closure of borders, which was at odds with them sharing the information in the first place, which I think sort of demands that we rethink sort of transactional approach to health security that has often been the case. And as you say, I think we need to figure out some of these answers in a more nuanced framing moving forward, because the impending global health threats of the future are going to be even more challenging to deal with if we don't. Yeah.
You mentioned zoonotic infections, and that ties us so beautifully into the One Health agenda, which is something, again, in the Bay Area, the greater Bay Area, sort of down the road from me in Sacramento and up the road from you in San Francisco at UC Davis. This idea that we're sort of impinging upon animal habitats increasingly and putting them and us at risk of new bugs, new bacteria, new viruses that we might not have encountered in the past. And I think that that's another area where we really haven't appreciated just what human civilization is doing that is putting us at risk, as well as the broader global microbiome, for want of a better phrase. And I get frustrated that we aren't able to pool that more into a better understanding of global health, solidarity, security, whatever we want to call it.
Yeah, I think you're right. I think there are grounds for optimism. I think some of our emerging technologies, our ability to do wastewater surveillance, will afford us the capacity to better detect infectious disease threats both from humans, but also from animals, in a way that could afford us that kind of more integrated approach to planetary health. But for sure, the risk of zoonotic infections is only going to increase as the planet warms. I think there's a lot of compelling data to show that. And moreover, as sort of urbanization encroaches on rural settings, the risk of spillover will only increase. I'm not an area where I'm an expert at all, but certainly I think we must and need to strengthen our capacity to both mitigate and respond to zoonotic infections if we are to protect ourselves from the next pandemic.
Well, it was COVID, it was, of course, or SARS-CoV-2, it was, I suppose, also HIV coming out of what is now called the Democratic Republic of Congo, and the experience that I guess came from exploitation through colonialism, but hindsight is 2020, isn't it? Changing tack a little bit, and I know this is an area of great interest to you, innovations through health technology, and particularly the potential of artificial intelligence. I was really keen to understand from you your excitement and not only the overall potential of this sort of new sunrise, but particularly what technologies you are excited about. I've done a number of podcasts in recent weeks with thinkers that are asking the good and the tough questions about how AI can help deliver health equity around the world. But I'm really keen to sort of understand where those technologies could actually apply, as well as understanding what technologies we need to watch out for and adapt so that we can be protected.
Yeah, I too share that excitement for the potential of AI to change global health. But I do think it's important that we're asking the right questions, right? I think too often the conversation is about using AI to make rich country tools cheaper or faster. And I think you're right. What we need instead is an equity first lens. How can AI improve diagnosis, prediction of diseases? How can it support community health workers when the workforce is thin in resource constrained settings? So my primary expertise is really related to HIV, and I think I'm excited around how AI can help with HIV surveillance, early detection, even epidemic forecasting, but it could also help us to support people to stay on lifelong treatment longer. I think it's also fair to say, though, that AI could widen inequities if we don't invest in the local infrastructure and governance and data sovereignty that is necessary. And as a consequence, I think there is a very important necessity to ensure that we invest in digital public goods, making sure that AI tools are open, adaptable, locally owned, and they serve public value. And so in that capacity, or in that context, I'm serving as the chair of the Lancet Global Health Commission on HIV and AI, and we're really trying to think through this, taking an optimistic lens about the future of AI, but mindful of the kinds of missteps that can result. We want to ask questions around how and where should AI be employed to advance HIV programs, and what are the necessary data and governance infrastructure that we need to invest in to ensure that. I could give you some examples of where we think it could play a role if you're interested.
Oh, yes.
Yeah. Well, I think there's a lot of interest in using AI to help with triage algorithms so that we can optimize scarce resources to the right client populations. And that's great. But I think if the triage algorithm is trained on Western data, it will deprioritize rural African women because it never learned to train on those, right? And so I think we need to ensure that we are centering context in the development of those algorithms. There's a lot of excitement around diagnostic tools. For example, AI to augment TB detection using chest X-ray machines. But if those diagnostic tools are imported into Africa without being appropriately reviewed, then there's a risk that they'll fail to miss TB in children. And so we need to ensure that the right governance and regulation is there, that these are not just seen as software, but as tools that need to be regulated, standards that need to be localized and piloted, and then needs post-market surveillance.
I was just thinking, I had got very excited about the idea that AI could break down the barriers between the local community clinic, the primary care, secondary care, and then the reference tertiary hospital. Listen to me sounding so 1950s National Health Service Britain. We'll come back to that. But the idea that the community health worker in rural Tanzania could connect with the reference laboratory, say in Dar es Salaam, or even in the Infectious Disease Institute in Makerere University in Uganda, and have a diagnosis come really, really quickly, electronically, that could help provide information about a patient's disease status. But that could only work, I understand now, could only work if the algorithm was designed for rural African women, East African women, as opposed to, in the case of HIV, gay white men living in urban San Francisco or, New York. And so how are you thinking that we might be able to change that? We're always talking about changing the paradigm, but really encourage the development of algorithms that prioritize the needs of rural African communities as much as well-off gay urban communities.
Well, I mean, it's a great point, and I think I would say that how we think about implementation of these tools is critical, right? So tools built in labs often fail in clinics, whether it's San Francisco or Kampala, especially when they're not adapted to local contexts, cultures, languages. And I think as we think about implementation of AI, we need to be designing these tools with local partners, ensuring that they're aligned to local system capacities. Because that's the other thing, is that you could have a tool that works really well, but if it leads to a clinic being completely overwhelmed because there aren't enough healthcare workers to respond to the need, then it doesn't matter what AI prioritizes. You're at risk for sort of eroding trust. And so you need to anchor these developments in the rights, the equities, the public health goals of the local community. And so these are things that the Lancet Commission is really trying to wrestle through? Can we come up with a set of digital principles that could inform how donors prioritize these resources? Can we think through an implementation science agenda for scaling AI tools? And then in addition, can we champion the idea of model cards or the ingredients on the back of the packet? You're probably familiar with this, but there's a lot of discourse now around how we should provide some explanation for an AI tool, just like you have ingredients on the back of your cereal box. And can we ensure that that is standardized across global health applications of AI tools? So these are the kinds of things that the Lancet Commission on AI and HIV will be discussing. One last thing before you ask me another question, though, and that is just a sober reflection on the reality that AI is not a silver bullet, and it will not replace healthcare workers. And I think the reality of the moment we live in is one where there is insufficient and diminishing resources for health. And there is a kind of heady expectation in certain quarters that AI will be able to solve the problems that resulting from contracting donor resources. And I personally do not feel that is a useful conversation. AI will not be able to replace frontline healthcare workers, community healthcare workers. It will not be able to offer the kind of compassionate care that a peer educator would be able to offer. And it won't replace drugs. We still need resources to provide these essential commodities.
But what it will do is perhaps speed up some of the decision making and help us deal with perhaps some of the loss to follow-up. Now, one of your Lancet Commission colleagues, Solange Baptiste, was just on the show, just on a very recent episode, and she had two really interesting things to say. The first is that she felt that perhaps in the very early stages of dealing with diagnosis, that perhaps the sort of impersonal side of AI providing information about diagnosis or even risks associated with HIV, that actually could be quite helpful and useful for people because it wouldn't come with the values that perhaps a healthcare provider might provide. And I thought that was very interesting, given, and we'll come on to this in a minute when we talk about the sort of mis and disinformation that has flourished with the growth of technology more broadly. But of course, the other thing is, particularly in countries where communities most at risk of HIV, we say HIV, but it could be anything really, but where communities who are perhaps excluded from society could perhaps be persecuted, perhaps are afraid of being connected to health services, and certainly very reticent about connecting their information, personal information, into government record systems. That's something that actually could be a real risk with the emergence of AI-related electronic medical records. And Solange was very clear about the importance of needing to find protections, even if in countries they were seen as ways of being something that could really improve the quality, in inverted commas, of services. And I don't know if you've got thoughts about those two things.
No, I mean, I think that, Solange, not surprisingly, very insightful in her comments. I am worried that the impact of AI will be determined by who has access to the data. And if you are a member of a vulnerable or marginalized community that is at risk for HIV acquisition, but also at risk from unfavorable political constituencies, then AI tools could put you at risk if they're used inappropriately. Which is why I think model cards, as I said before, could be a useful tool insofar as that would enable a sort of a transparency around how they're used and applied, what are the relative risks for different communities, What is the impact of the different AI tool? It certainly, I think, would be one part of a solution to how we can mitigate some of those potential threats. I would also say, and I think there is increasing discourse around the need to recognize that the algorithms that AI is built on are informed by embodied data, by the information of the communities they serve. It's not just zeros and ones, it's people's lives. And I think there is a really important role for civil society and community voices, the likes of which the Lounge represents, to really play a more strident role in determining how and where AI is used so that some of these threats and risks are not taken advantage of.
Now, in terms of these protections and keeping this as transparent, as open as possible, here we are recording and releasing this at the start of the World Health Assembly. Where do you see this repository, this sort of, this sort of multilateral regulatory home being? Because it probably isn't inaccurate to say that we don't really have anything that's fit for purpose at the moment.
You mean in terms of global health governance?
Yeah.
Oh, wow. That's a really big question. I mean, I'm sure that many of the people you've spoken to on this podcast have sort of spoken about the fact that we're at an important inflection point, right? My personal feeling is that, we do need to reimagine the World Health Assembly and WHO in this moment. Some will argue it's too bureaucratic, it's beholden to big donors, it is constrained by earmarked resources. And we need to imagine a future in global health that is multipolar, that is more pluralistic, that speaks to or enables the voices of more diverse constituents to be represented. But in reality, I think what that looks like might involve less focus on activities in Geneva and more emphasis on the regional activities of WHO. And so as I think about sort of trying to answer your question and the sort of future of global health governance, I think I would be inclined to advocate for a greater focus on investments at a regional level, and also a shift in how WHO is funded so that there aren't those, the biases or distortions that result from one or two member states and or philanthropy driving the agendas of the world's normative agency. And then I think WHO should do what it's really good at, which is developing normative guidelines and being responsive to emerging infectious disease threats, etc., rather than all of these other things. So I know that you're probably going to have a podcast on the impending cuts to WHO and all the implications of that. I think there's grounds for sort of being sanguine or hesitant about the implications of those things. But there's also an opportunity to really use this as a moment to rethink the functions, the architecture, the funding of WHO in a way that could really drive change in positive ways.
Well, I think that's the opportunity of the moment. There can be a lot of gnashing of teeth and wrenching of clothes about how the post-war compact and certainly the post-Cold War compact has come to an end, but it wasn't perfect. And I think we have the opportunity collectively to now create what we want. Okay, we won't have the resources that we necessarily hoped we were going to have or assumed we were going to have, but we can start to create what is needed for the next phase. And I think there's an interesting thing in what you said, that WHO should focus on its normative guidelines. And that makes sense when we understand what it is that it needs to offer normative guidelines around. It may be the case that offering normative guidelines on how AI should be utilized in the diagnosis of infectious disease may be something down the line that we need to consider. And so that flexibility, I think, is going to be needed there. But I also think that your point around getting out of Geneva is absolutely right. And I need to do my homework and remember which of the many, many science fiction and dystopian future novels that I read refer to Zimbabwe as the future Switzerland of the world, and that the UN is based in Zimbabwe, and that Kenya becomes the space hub for the future, the world's future space agency. And I think there's going to be a case, and of course, the 21st century is Africa's century. Maybe towards the end of our lives, we will see things that are very, very different to what we see in Geneva in the middle of May 2025. I wanted to turn the attention a little bit to your reflections as a practitioner on mis and disinformation. There are two entry points to this. The first is that we are in the midst of an industrial revolution, a tech industrial revolution. And in many ways, there's nothing new about mis and disinformation in health. We've all had snake oil salesman stories since time immemorial. And perhaps there's really nothing new about, say, take vitamin A or vitamin E or whatever to combat measles. Don't quote me on that. But there's also something about the way in which Dr. Google or Dr. X allows us to find information that we want to find in ways that allow us to challenge more traditional sources of information. And for those of us coming from the AIDS movement, we really were part of a skeptical approach to empiric Western medicine in a way that we didn't throw the baby out of the bathwater, but we demanded changes to the way that new medications were researched, that we had seats at the table. And again, going back to Yvette Raphael, she's won this award from the American Academy of Sciences for the development of lenacapavir, the long-acting injectable. As the chair of the Global Accountability Board, getting the engagement of pregnant women in a prevention trial that's been unheard of. It would be impossible to do before. And so we've been part of this evolution of changes to the way we think of medicine. So I just wanted to see from your experience, and I know it's not something that you delved so deeply into, but how you as a practitioner have navigated these waters.
Yeah, well, I have two answers for you, Ben. One is as a clinician and one as a sort of a global health professional. So I think when I think about issues of disinformation or misinformation as they relate to the clients, the recipients of care I engage with, I can't emphasize enough the importance of trust and how important it is to have an effective therapeutic relationship with clients. And we saw that so often during COVID that was undermined by structural racial inequities and a lack of cultural humility. And certainly in my own practice, I'm keenly aware that I am most effective at addressing misinformation when I have an effective therapeutic relationship with patients that is based on trust and mutual collaboration. Maybe sort of zooming out and answering this question from a global health perspective, though, because I think it's a really important question that it again is really relevant to the broader discourse around what the future of global health is. And I think of like this topic within the broader topic of or context of epistemology, how we make sense of the world and our understanding of knowing, which is so relevant to the future of global health. And in my opinion, as we think about the future of global health, this is just my terminology, but we need a both and approach. We need to recognize the value both of medical science and indigenous knowledge. both quantitative data and lived experience, randomized controlled trials and community-based insights. And I think global health has long privileged one form of evidence over another, right? Dominant cultural force over another, high income versus low income, northern versus southern, biomedical versus indigenous. And I think, moving forward to reimagine global health, we need to embrace a form of epistemic pluralism. We need to create better spaces, or rather more spaces for co-created knowledge and humility in the face of complexity. And I think that's going to be crucial to the future of global health, just as is redefining governance, as we were talking about earlier. And the two things are really related, right? We fundamentally need to rethink who has voices and powers in setting priorities and shaping the future of global health. And this means moving away from the hierarchical, donor-driven governance models that are based off of one particular epistemic view of the world to a more inclusive, decentralized, regionally grounded structure. So those two things I think are kind of related, even though your questions were somewhat different. Yeah.
No, I think they are absolutely related. And I think, as much as it is evolving the relationship between donor and recipient, it is changing the relationship between doctor and patient, doctor and consumer of care. And I think that's one of the things that certainly HIV has taught us. So I know we're getting up to the top of the hour. There's one other area that I wanted to cover with you in this podcast. I think there's a lot we will need to come back to in future episodes, Mike. But again, coming back to the fact that you and I have similar accents, we were brought up in a very particular form of healthcare delivery, the National Health Service, and free healthcare at the point of delivery. I am a proud supporter of Aneurin Nye Bevan, who was the founder of the National Health Service. And there's one quote, and I'm just going to reiterate it here, which is that he said, "No society can legitimately call itself civilized if a sick person is denied medical aid because of lack of means." And that has really driven me throughout both my professional and personal life. And I wonder how you have adapted to the various different models of healthcare, because there is not one model in the United States. It's a mishmash of various. How have you acclimatized from an NHS to a plethora of systems in the US?
Wow. Yeah. I mean, let me just start by sort of validating your experience. That was definitely mine growing up. I took for granted that healthcare was a right? And in fact, my parents have been served by the same general practice, the same doctor for the last 30 years, and they've never had to think about paying for any of their services. And I think that the impact on their mental health, or maybe I should say not having to address all of the stresses of finding healthcare or paying for it, has, I think, been significant. But reflecting on the US, I think in the US, you quickly learn that it's something you have to earn or buy. And I think that shapes many aspects of my interactions with patients, but also policymaking in terms of what services are available to a community or not. I would say that there are advantages to the US system, right? The US leads on innovation and speed. There are services and ways that things are done that are far superior to what's offered in aspects of the UK system. But the UK system leads in access and arguably in public trust. I think, as it relates to global health, we probably can learn from both, right? We need the ambition of American science paired with the commitment to universality that the NHS embodies. So I guess that's a kind of a response to your question.
Yeah, you might say it's a cop-out, Mike, but actually, I wouldn't disagree with you, because I think there's a sort of a confluence here. Some might say, oh, well, actually, it's, insurance-based systems, as you see in continental Europe, are the way to go. But actually, free at the point of delivery doesn't mean to say that the delivery has to be nationalized. It can be paid for by national insurance, let's say, but it doesn't have to be delivered by national insurance. So I think as again, we're living through this new tech industrial revolution, what Nye Bevan came up with in 1940, 1945, 1948 doesn't necessarily apply wholeheartedly in 2025. So I think it's a very interesting journey, and one that people like you and me, English Americans, British Americans, that I think we have a big contribution to make.
That's right. Yeah, I agree. I would also just add that, I think, every country gets to decide its own trajectory in terms of how it offers services. And so imposing one form of health service delivery on a country, whether it's a national health service system or a privatized healthcare system, could amount to another form of coloniality if you're not careful. And I think the example here of TB is really worth drawing attention to. For the longest time, there has been a sensibility that the best way to control TB globally is to invest in public TB systems, national TB programs. And I think that's absolutely true. But the reality is that in many parts of the world where TB is a big problem, thinking here of the Philippines or India, for example, there's a very vibrant private healthcare system. And people prefer to go to the private healthcare system. And so in those settings, TB control efforts need to really invest in private infrastructure if they're going to address the problem. And so all of that to say that there is no one size fits all, and what works in the UK might not work in India or the US. And each country needs to determine how it's going to solve these problems, with the caveat that I think governments always have a responsibility to close equity gaps. In countries, even the wealthiest countries in the world, it's the responsibility of governments to look after those most vulnerable. And when they fail to do that, they fail to fulfill their political mandate.
And taking us back to health technologies and AI, your comment about the private sector, whether it's in the form of non-profits or subsidized care or cooperatives, those are precisely areas that could provide care and support to marginalized populations that don't feel comfortable connecting to large state services. It's all up for grabs.
Yeah, I agree.
Well, what a fascinating conversation, Mike. Really appreciate you coming on the show finally, and us being able to chew the cud on a range of really crucial issues that are going to be facing the global health field in the coming years. So thank you so much.
If you are happy to have me on again, I'd love to come and talk more about the HIV Commission. I'm also very interested in sovereign wealth funds and how we could use those in global health. Have a Substack out there coming out next week on how Bill Gates should give all of his money to sovereign wealth funds in the global south. Encourage your readers or your listeners to read that if they have time. But this was a pleasure. Thank you for finding the time to invite me.
And we will include your Substack in the show notes. And I encourage all our listeners and viewers to visit it and subscribe. So yeah, brilliant. Well, thanks, Mike.
Thanks, Ben. Good to be with you.
Well, that's it for this episode. Thanks to Mike Reid. Thanks also to our director and producer, Erica Spera of A Shot in the Arm Media. And finally, a big thanks to you. You can find us wherever you download your podcasts. And don't forget to check us out on our YouTube channel. You can like this episode and subscribe. Well, with that, have a great week and a safe week, everyone.